All right, so hi, we're so glad you could make it. Thank you for making the time to be here. I'm Talia, if you didn't already know, and I am the content and community manager here at Hugo Health Kindred. For those of you who don't know, Kindred is building a network of data-enabled people who have been impacted by COVID and want to contribute to research in partnership with leading scientists. I strongly encourage anyone who is not a member yet to join us. You can go to kindred.hugo.health for more information, and it is from Kindred that you can enroll in the Yale Listen Study led by Drs. Iwasaki and Krumholtz. And if you're living with long COVID, we also have a PAX LC trial now available or now screening on Kindred. We just opened it up to a whole bunch more states. So please log into the app and check to see if you're possibly eligible. It'll show up on the right-hand side of the homepage under Kindred Research Studies. And if you have any questions about that, you can reach out to me. And if I can't answer your question, I can connect you with the appropriate person. We are so excited to have Dr. Lindsay McAlpine here. She is a neuroimmunologist and an instructor in the Division of Neurological Infections and Global Neurology at the Yale University School of Medicine. She started a NeuroCOVID Clinic at Yale in October 2020 and sees patients with neurological issues related to long COVID, among other things. So we're going to run this the way we usually do with the Kindred Cafes. So we have Pam and Denise here. Denise is living with vaccine injury and Pam is living with long COVID. They're going to tell a little bit about themselves and their stories, and then they're going to ask Lindsay a few questions as it pertains to the whole community, and then we'll have time for some live Q&A in the end. Regarding the chat and the Q&A, the chat is a really great place for you guys to connect with each other, share any tips on symptom management or anything that's worked for you, or support or doctors, anything like that. We are actually compiling, you could save the chats after these meetings. So we are actually compiling all the chats with that information and creating a resource document for Kindred members, but also to post online and share with anyone dealing with these conditions. So definitely take advantage of that and use the chat. If you have any questions about Kindred, like how to connect your data or how to enroll in research or anything like that, I would recommend that you shoot me an email, talia@hugo.health. Because I'm not sure, a lot to look on the screen, so I'm not sure if I'll be able to see those questions, and I want to make sure that they're answered. So please shoot that to me if you have any questions. Yeah, and I think that is it. Let me check my notes. Yeah, so we're just going to dive right in. And we'll start with Denise, if you'd like to share your story.
Everyone, my name is Denise Hertz. I'm a 66-year-old retired gastroenterologist in Los Angeles, California. In December of 2020, 2 months after retiring, I received my first and only Pfizer vaccine. Within 30 minutes, I developed facial burning, blurred vision, ringing in my ears, numbness in my tongue, and a very high blood pressure. Within the next 24 to 48 hours, I became severely ill. I experienced loud tinnitus, double vision, severe burning pain, and numbness in the skin of my face and limbs, internal vibrations, tremors, twitching, a tight constricting band around my lower chest, dizziness, imbalance, trouble thinking, trouble speaking, chest pain, tachycardia, shortness of breath, and profound weakness. At times, I felt an excruciating electric current running through my body. I quickly sought medical care here in Los Angeles, as well as across the country, including the NIH, Stanford, Harvard, and Mount Sinai. 31 months and 25 doctors later, I have been diagnosed with mast cell activation syndrome, small fiber neuropathy, dysautonomia and POTS, and pericarditis. I have tried many medications and am currently on gabapentin, Inderal, Claritin, Pepcid, colchicine, aspirin, and many supplements. I tried subcutaneous immunoglobulins for 3 months, but they actually made me worse, so I stopped them. And most recently, I've been on low-dose naltrexone, as well as intermittent fasting, a low histamine diet, DAO supplements, and cromolyn before meals. I have been improving slowly over time, but I still have a long ways to go. That's my story.
Thank you, Denise. Pam, if you'd like to share your story.
Yes, thank you, Talia. Hi, I'm Pam Bishop. I contracted COVID in December of 2020, just a couple of days after my 45th birthday. Prior to that, I was a professor at a large research university. I was the director of my own research center, very busy, very fit, active, healthy, no comorbidities or anything that would indicate that I would have a problem worse than anyone else with tracking COVID. My first symptom was similar to a lot of people back then. I lost my taste and smell. I very quickly became very sick for about 3 weeks. I wasn't hospitalized because back then, if your oxygen didn't dip, which mine didn't, there was nothing that the hospital could do for you. So I stayed home for about 3 weeks. My symptoms were very neurological in nature. I had a constant headache, nausea, fatigue, auditory and visual hallucinations, and derealization, and a lot of sleep disturbances, muscle twitches, just all sorts of things. So that went on for about 3 weeks. And then at the end of December, I was feeling better. I had Christmas with my husband and my kids, and thought it was all behind us. Went back to work in January, and I started having episodes of mostly major fatigue, tachycardia, high heart rate, and the severe headache again. I would work. I was working from home, which I had been since March of 2020. On the computer, I would have a Zoom call, and then I'd have to lie in bed, and then I would get up and work again. I'd have to lie in bed, and those episodes started getting more frequent. And at first I thought maybe I just, I'd been through a lot. This was the healing process. And then as the episodes became more frequent, I realized that something was probably very wrong. So by the end of March, I was again sick every single day. So I got into a post-COVID clinic in April of 2021. Since that time, I've seen over 40 specialists, and 6 of those have been neurologists. So I'm really excited for Dr. McAlpine to talk about her experiences with patients today. You could probably guess that if I've been to 6 neurologists, the first 5 weren't great. So I'm really interested to hear what you have to say. So I've been diagnosed with dysautonomia, POTS in particular. It's pretty severe. I have ME/CFS now and mast cell activation syndrome. I have a lot of unexplained neurological symptoms. I have tremors in my hands, particularly if I overdo it, which is very easy to do. I get shooting pains in my head and my chest and my limbs sometimes. Lately, extreme dizziness when I'm lying down, which has not been an aspect of POTS that I've dealt with before. Involuntary muscle movements, and like Denise, I also have severe tinnitus. I've had it since I was infected in December of 2020, and it never goes away. It's very frustrating. So I, am just taking it day by day, just like everybody else out there. I've tried lots of different treatments. I was one of the crazy people who went to Europe and did help apheresis, which is a whole other story. It was the only thing that actually did help for about 6 weeks, and then I went back to baseline. So yeah, I've done a lot of self-experimentation, like a lot of people on this call. Nothing seems to help. I can manage the POTS symptoms, with compression and water and salt and things, the basics for POTS. Same with ME/CFS, pacing, mast cell activation, antihistamines, avoiding certain triggers. But my overall quality of life is probably 25% of what it was before I got COVID. So I'm really interested in hearing from Dr. McAlpine and hearing what she has to say about NeuroCOVID.
Thank you both so much for sharing. So we'll go right into questions. So Denise, if you want to start with your questions for Dr. McAlpine.
Dr. McAlpine, I know some of these questions are going to be difficult to answer, but my first question is, do you think long COVID and vaccine injury are the same or similar conditions? And if so, does this help us to determine the mechanism of injury or how to treat these conditions?
Uh-oh. Hold on.
That's me. Now
Yeah.
I'm muted. I think that's a great question. I have less experience with the vaccine injury because our clinic was only long COVID, because we had so much long COVID that we couldn't see all the patients with vaccine injury. But from my experience with it and from thinking about it theoretically, I do think there is probably a similar mechanism. And it depends on the underlying conditions as well. So mast cell, I think, is the number one thing that people with mast cell who are going about their lives are living normally. And then you put in a huge trigger, very large inflammatory trigger, and it changes. And that's what we know about mast cell, is it fluctuates a lot throughout somebody's lifetime. And so having that big trigger, I think is the common theme. And just like, you know, I typically classify ME, CFS as its own thing. I don't call it long COVID. I think people with long COVID have ME, CSF, FS. So I think that pathology itself is really existed for a very long time. People have been coming down with mono and the flu and other viruses that have triggered this. And so I think understanding how the inflammation impacts will be really helpful.
Denise, did you have another question?
Yeah, Denise, do you have another question?
Oh, do you want me to go? Okay.
Mhm.
Let's see. This is another question. Do you think that long COVID and vaccine injury will just predispose us to long-term consequences such as dementia or other neurodegenerative diseases? Is there anything we can do to prevent such a progression?
Right. I think that's a really important question. And I think that's on the minds of a lot of people on this call and a lot of my patients. And so far, we have no evidence for that. So I think that's reassuring. You know, in all of the, chronic fatigue studies, people have not gone on to develop neurodegenerative diseases. I do see neurodegenerative diseases in my clinic, but more because people who had these diseases smoldering, had COVID or vax, and went off the cliff and developed symptoms and were no longer able to cope or adapt. And so that's also common because dementia starts 15 years. It starts in the brain at least 15 years before anybody has a first symptom. So that disease process is going. And then any big illness or inflammatory illness can kind of, send people off that symptomatic cliff. So in my experience, no, I have not seen anybody gone on, caused by COVID, developed a neurodegenerative disease, but definitely has unmasked it, definitely.
Question. Some of the vaccine injured have syndromes that are very similar to well-known neurological diseases like MS, Parkinson's, ALS, and they've been given those diagnoses by their practitioners. And I know you're not seeing these patients, but do you believe that they actually have these diseases, or are they having another condition that is just mimicking or looking like ALS, looking like MS, but is really something different?
So I would say I think that kind of gets back to my last point, is that we've diagnosed, because I also treat MS, we've diagnosed a lot of new cases of MS after COVID, but MS didn't cause COVID. It's very common for people with autoimmune diseases to have flares with infections, because if you think about an infection, it's revving up your immune system. It's going to rev up your autoimmune disease, right? So we've diagnosed, and that's actually happened before, right? So people come in with other viral or other infections and they have an MS flare, and then they're diagnosed with MS, they develop optic neuritis or something. And ALS, absolutely, that's a specific pathological diagnosis based on the clinical exam and the EMG. And so, those things aren't, I think that's where this inflammation comes in unmasking these illnesses, and that the vaccine didn't necessarily cause it, but it was a trigger in it.
And I can just one last one, and then I'll pass it on to Pam. Do you believe that the neurological consequences of vaccine injury and long COVID are reversible? Is there a potential for full recovery?
That's a great question. And I don't know, so I'm not sure. I think, knowing patients who have lived with small fiber neuropathy, mast cell disorder, POTS, I think that it's possible to have a better quality of life with these disorders, and that throughout someone's lifetime, there's different waxing and waning of symptoms. And so and I've seen people recover quite well from the POTS and from the chronic fatigue. And so seeing that makes me hopeful and believe it. And what we don't know is kind of who are the people that don't get better and what's the difference between the people who do get better, and yeah.
Just anecdotally, in our cohort of injured, some people are recovering 100%, even if they started out quite ill at the beginning. Other people are smoldering. I would put myself in that group. And then there are those who are deteriorating. And I think it is really important to understand
why is somebody in each bucket. And the smoldering ones in my experience have been people with autoimmune disease underlying, much more likely to smolder. And I think that's related to the dysregulation of the immune system that happens after COVID. And that's part of an autoimmune disease. Yeah.
Thank you so much. Great questions, Denise. Pam, if you have some questions you'd like to ask as well.
Sure. Thank you. And Denise, those were really great questions. From the science side of things, there are a lot of big questions that we have, and I appreciate Dr. McAlpine, you saying that you don't know. It's hard to get doctors to say that when you're in the room with them. So my question is, from like a pragmatic standpoint as a patient. So as I mentioned, I've seen more than 40 specialists since I've been sick. 6 of those have been neurologists. In my experience, and I know in the experience of a lot of people on this call, neurology has been the most difficult profession to deal with, in that I think that seems to be the discipline in which most of us experience the most gaslighting, the most dismissal, the most unwillingness to say, I don't know, and more willingness to blame the patient and say it's psychosomatic and all of these things. And I'm sure that you're well aware of this. So I'm just curious, so as a neurologist who does treat people with long COVID, what advice can you give to us as the patients to get the most out of a neurology appointment? So when we go in for, whatever symptoms we're dealing with, as an MD, what is the most helpful to you when a patient comes in, first time with long COVID? What would you look for that would be helpful?
Oh gosh, that is a good question and not one I've thought of. I would say focus on the symptom that is bothering you the most. So I wouldn't necessarily give them the kitchen sink, because I think they'll get distracted, and then they'll get like, well, I don't know, and then shut down, kind of thing. And so I would say, like, if you want to go in and say, my dizziness is really, really bad, my vertigo is really bad, or my headaches have been excruciating since COVID. And like, once you develop a relationship with the neurologist and they know you as a patient, you can bring up some more of the issues that you want to address later on. So I would just have that expectation, because it is hard, like, to address 10 issues in one visit. And so kind of taking it step by step, developing that relationship. And I feel like you're a lot less likely to be dismissed as like, oh, she's like just anxious or whatever. You know what I mean? So I think that would be probably my best advice. And it takes time too. And so it's like the expectation of like, we're going to have a fix is not real, even in my clinic, right? There is no easy, quick fix. And so there's a lot of trial and error. And you all know it's really hard to have patience through all the trial and error and figuring out what works and what doesn't work and what's actually going on and what's not going on, ruling out the things that we really need to make sure we're not missing.
Thank you for that. That's actually really helpful. I know, a lot of us have so many symptoms happening that, I can see how it would be overwhelming for an MD when you come in and you say, I have these 10 neurological things that are happening, and it's hard to address all of those at once. So I can understand how that would be difficult. I thought of another question. Oh, my memory is so bad now. I can't remember what it was. It had to do with something that you said, and I'm so sorry. I have.
That's okay.
I don't write things down. I do have another question, and maybe that one will come back to me. Do you see? I know a lot of people have migraines that they either had them before long COVID or that they've developed them after, or they've gotten worse. In my case, I had them before and they've gotten worse since I've had long COVID. Do you see some sort of correlation between that? And, what are your thoughts on why that might be happening and what people can do about it? I know a lot of people are really suffering with those.
Yeah, all the time. I see that all the time. So either new migraines after COVID or worsening migraines after COVID. And again, I think it goes like migraine, I think of as the classic chronic neurologic disease that you live with throughout your life. Doesn't like kill you, but it waxes and wanes throughout your life. And COVID is one of those monster triggers that triggers the inflammation, and so people have a lot of worsening of migraine afterwards. And so I use the typical treatments. I do find that there's other things that contribute. Like one of the big things for me is sleep that I focus on with all patients, is making sure they're getting enough rest. For whatever reason, patients with long COVID they're much more sensitive to sleep deprivation and disruption. And so when they could tolerate like 5-6 hours before COVID, now they cannot, right? Now their migraines are worse. Now they're dizzy, all the symptoms are worse. And so that's a huge one. Is I've diagnosed countless cases of new sleep apnea, and treated a lot of not anxiety, but insomnia with CBT, which is an anxiety treatment also, to improve patients' sleep. And that is makes the biggest difference, I would say, in quality of life, and has a ripple effect on the cognitive symptoms, on the migraines, on really everything, the fatigue, everything. So that's one of the big things that I focus on. And so I've had a lot of patients recently. I wake up with, migraine. And so we address the sleep, we're addressing diet, exercise, hydration, all of the things. Exercise is hard with our chronic fatigue patients, and then using similar treatments, that we use for classic migraine, but in a smart way. Like I won't use Topamax usually as a preventative medicine in my long COVID group because they already have brain fog. I don't need to give them more brain fog. I will try and use propranolol in people who have POTS. I've had a lot of patients respond really well to propranolol trials and therapies. And then, escalating when necessary, trying Botox, trying the injectable medicines, Emgality or Aimovig. Comes to migraine.
Great. And that's, I really appreciate you saying that about Topamax as someone who tried it. I've been on it a couple of times before. I had long COVID. Yeah. I always said it felt like living in a fishbowl. It was not pleasant. So I have actually one last question, and then I know we need to get to our community questions. How would you suggest? So I do this a lot. I read a lot of research. I was a researcher before I got sick. So, I'm always reading research on long COVID. And I tend to bring that research in with me to doctor's appointments. Some doctors aren't crazy about that. And I don't know if it's insulting or if it's just they don't have the time for it or what have you. So what is your opinion on the patient bringing in, and I know you're probably more open to this because you're you
Oh,
or
sure.
the other neurologists that we all see. But yeah, could you give us your take on how to, so for instance, if you have a symptom and you've been reading research on it and you think that it might be, might be related to this research or something like that, and you bring it in and the doctor doesn't know anything about it. Yeah, what is your take on that? Because I tend to be take notes and bring papers and mixed reviews on that from doctors.
Yeah, I mean, I really like it when my patients send me research because I can't keep up with everything, right? So I do appreciate when there's like other things. I usually will read the abstract. So like if you want to bring in the abstract, that's useful, and I can usually have a litmus test of like, oh, this is relevant or this isn't relevant, so I think it just depends on the person too, 1 or 2 abstracts, I would limit it to that. Yeah.
Understood. All right.
Yeah.
So I know we're getting close to the end of the hour. So we just our public questions. Thank you very much, Dr. McAlpine.
Sure.
Thank you so much, Pam and Denise and Dr. McAlpine. I wanted to, Dr. McAlpine, I know that I sort of rushed into this when we started. So I wanted to see if you had something that you wanted to say, anything about, the research that you're doing that you wanted to speak about. We could do that now, or we could use the time for the live Q&A. So.
Yeah, I just some general things that I like to remind a lot of my patients or let them know is that, this is a long journey. From in my experience, usually people are recovering, anywhere from 12 to 24 months out. And so it's this like long journey, and to have that patience and that hope that you will turn around. Because I do see a lot of people come in, I feel so much better, this is not better, and people get back to 85, 90, 95%, 100% of what they were, and so I think that's always, because I think it's a really hard experience to go through. And so having that perspective and hope that you will and can get better, and that, addressing all of these things that you can, like I said, sleep, underlying autoimmune disease, all of these things. One of the main things I do in my clinic is make sure we're not missing something else that could be treated and make you feel better, and kind of saying, yes, this is due to long COVID, we can stop looking, and no, this really, I don't think this is long COVID. Like, we need to keep looking at this and figuring out what that is, so also being open to things that aren't long COVID that could be addressed, and then my research is exciting. We, are enrolling patients and doing really deep dives. So we do blood, we do spinal fluid, we do an MRI, we do 3.5 hours of neuropsychological testing. We're really trying to understand the pathophysiology of this disease. So I think participating in research in whatever city you're in, you guys are all clearly a really motivated group. So I think that's really wonderful. And my project really focuses on looking at the vascular inflammation related to long COVID. And so that we're finding in some of our preliminary data that there is this smoldering elevated vascular inflammation, which I think is where the microclots come in. Like, I don't, in my experience, think there are microclots themselves, but there's inflammation in the vessel wall. So it's just kind of 2 sides of the same coin, if that makes sense. So there's the vessel wall is activated and inflamed and causing symptoms. Yeah.
Thank you so
Which
much.
can unify PASC among all organ systems, right? So if there's vascular dysfunction, can explain a lot of things. Yeah.
Thank you. Those
So
are all
questions, yeah.
really interesting and important. Yeah, we're going to go into questions now. Just a reminder, if you have questions for Dr. McAlpine, please put that in the Q&A and not the chat. Right now we have 58 questions, which is amazing. Thank you so much. But we're only going to run this event until about 5:10. So if we don't get to your questions, I apologize ahead of time. Doing our best, but keep them coming. And thank you
I'll
so
try
much
and
for being
answer them
here.
in some other forum, maybe Twitter at some point. Follow me on
Thank you.
Twitter.
It's
I'll
amazing.
try and answer them.
We'll
Yeah.
get them answered.
I don't
so keep
want
them
people to
coming.
go, yeah.
Thanks so much.
Yeah.
So let's start with the first one. We have from Kevin. Can you briefly mention the theories on what causes persistent neurological COVID symptoms and what traction each has, e.g. autoimmune reaction, persistent virus, viral remnants, etc.?
I think that's a great question. So viral remnants is definitely on the list. We have evidence of it in the gut. We don't have any evidence of it in the brain. So, because it's not easy to get tissue in the brain, right? So we know that there is viral persistence in the gut. I'm not sure if that's going on in the brain. Interestingly, in our cytokine study, looking at cytokines in the CSF in the blood, we actually didn't find any elevation. So to me, that's saying that maybe there is no viral well, we know there's no viral persistence, but antigen persistent in the spinal fluid or in the brain, because we would have that elevated inflammation, as we've seen with other viruses and infections. No viral persistence. So replicating virus, I would say definitely not. Even in acute COVID, we didn't find replicating virus in the spinal fluid. So I think that one we've kind of put more to rest. The autoimmune, I think it depends on the person. And it depends on if the person has other autoimmune disease or other autoimmune tendency, because autoimmune disease really runs in the family and is a genetic condition in a lot of ways with environmental factors like COVID or mono or other things. One of the things that I think I saw mentioned in one of the questions that is big on my mind is that in the chronic fatigue pathology, that there is poor oxygen extraction out of the blood. I think that's and dysregulation of the small vessels in the tissues, which is why people we think why they can't tolerate activity and why exercise doesn't provide a benefit, because you're going to just crash and that you're not able to, your tissues aren't working properly. And the brain is an exquisitely sensitive organ to any sort of dysregulation. And so if there's that vascular dysregulation, that tissue oxygen extraction issue going on in the brain, you're going to have brain fog and cognitive symptoms from it. And so that's one of the things that I think why people with POTS, why people with chronic fatigue are having cognitive symptoms that are episodic as well and correlate with flares. So it makes a lot of sense. But the question is, how do we treat it? How do we fix it? I'm a big fan of the dysautonomia PT protocol. I've had a lot of responders to that. So I think that's a really, really, really good place to start. There are non-responders and we don't know why. So that's the other question, is why people are falling in those buckets. PT is in physical therapy. Yes. So the dysautonomia, chronic fatigue, very gradual return to activity. The way I think about it is you're retraining your tissues to work properly, and sometimes it works. A lot of times it works. Sometimes it doesn't. So, yeah.
Thank you so much. That was great.
Yeah.
Next question from Adeline. Dr. McAlpine, and I apologize if I mispronounce any
No, that's right.
terms.
Okay.
Can you shine any light on prurigo nodularis, a neuroimmune disorder which some vaccine injured suffer from or is in the dermatology silo?
Prurigo nodularis, I don't know that one. I'm not sure.
Okay.
Yeah. Sorry.
I'll move on to the no. Thank you for saying. We have a question from Cindy. I have LC with dysautonomia and ME/CFS. A symptom that really concerns me is numbness, tingling, neuropathy type issues in feet and hands. Do you see this often, and when do you need to rule out other disorders, and what are those?
Yeah. So, immediately when Dr. Hertz said her symptoms, I was like, small fiber neuropathy, because I see it so much. And I've been meaning to publish my paper for a while. I have a case series in response to IVIG. And so, the evidence out there is mixed. I'm going to put my 2 cents out there someday, soon, hopefully. But I would, in anybody who has persistent numbness and tingling, clumsiness, burning, hypersensitivity, we call it allodynia, where your skin is like, some people described it as a sunburn or feeling like even a little bit really, really hurts. Everybody should get a full neuropathy workup, full labs, full nerve conduction study. And then if all of that is normal, which we kind of expect it to be normal, then you get the skin biopsy for small fiber neuropathy for diagnosis. And that can give you an answer. Whether you respond to treatment or not is individual. But I think having an answer and a lot of patients having that validation is really important.
Sure. Thank you. We have another question. Have you seen post-COVID neuro patients end up with worse outcomes after subsequent COVID infections, or is their risk profile about the same as the general population?
Yeah. So that's one thing that heartened me a little bit is that when patients with long COVID were getting COVID again, as inevitable as it is, they were not getting worse or falling off a cliff or having a complete resurgence of their long COVID symptoms, which was really good news and makes sense to me. There's something about that first illness, excuse me, that terrible inflammation of the first illness that really sets the ball in motion. But your body, if you're vaccinated, if you were able to get vaccinated successfully without issues, you're vaccinated, you have some immunity, you're not going to get as bad, you're not going to have as worse inflammation and may not have worsening symptoms, so I think that was always very encouraging to me. And, some people actually, when they got vaccinated after long COVID, they even got better, which kind of made that antigen persistence question a bigger question in my mind. That what we called it therapeutic vaccination is that maybe you're clearing that persistent antigen that's circulating. But again, we don't have that. It's in theory. Yeah.
Thank you. Next question is from Jeffrey. He asks, do you have any familiarity with IVIG therapy for cognitive symptoms? How about plasmapheresis?
Oh, that's very interesting, but no, because insurance will never pay for that ever. So I know that Avi Nath at NIH was doing a study on IVIG, but I haven't seen any results from that yet. But it is really hard to get IVIG covered by insurance, and then it is a very, very expensive treatment. So no, I would love to have data on that, but I don't.
Got another one from Cindy. Have you heard of used high dose Pepcid for LC neuroinflammation, 40 milligrams TID?
Definitely, that would be treating the mast cell activation syndrome. So that, usually mast cell is, it's an antihistamine like Claritin or Zyrtec or something, and then it's Pepcid, and then there's a whole other slew of natural and prescription drugs that you can try.
Great, super helpful. And then we have a question from Linda. Hi, Dr. McAlpine. I'm your patient at Yale Clinic, and I've been taking the Lowdose Naltrexone that you prescribed for me post-COVID tinnitus. Could you please talk about results you've seen with this protocol and any other treatment that might have promise? Thank you.
Yeah, the tinnitus is not fully in my specialty because it's mostly an ENT condition. And from what I've discuss with other ENTs is with the tinnitus, they fix the hearing, they address the hearing loss, and then they say you're kind of stuck with it. And so, I am open to trying different things based on the risk profile. So low-dose naltrexone is one of those things that I don't think has a lot of great evidence. And in my experience with patients, it's responders and non-responders. So it's kind of half and half, people who get a benefit from it and who don't. But it has a low risk side effects. And so we try it for these things. And I think I've looked on clinicaltrials.gov. There are studies coming out on the effects of low-dose naltrexone, and so we'll find out.
Great. A question from Tracy. Thank you for this forum and your participation. Any thoughts on managing light and/or sound sensitivity?
Oh, yeah. So light and sound sensitivity comes in with typically in people with chronic migraine. Migraine is like a whole body experience, the vagus nerves involved, there's gastroparesis and nausea, there's the hypersensitivity to sound, noise, smell. And so usually our approach is to manage the headache and the migraine and to raise that threshold, that migraine threshold. And a lot of things can lower it, sleep, stress, alcohol, all those things. And so we work on all of those things that we can do to kind of calm the nervous system down. One of the things that has good evidence is actually yoga in migraine. And so another way to give some feedback, because I think a lot of the behavioral mood things actually have an effect on our body. It's like cognition and body. You can't really separate those things as much as we want to say they are. So addressing, mood, anxiety, sleep, all of that is really, really important for quality of life and basically like allowing yourself to heal. Those are roadblocks, things that can get in the way of you healing and feeling better. So anyway, the long-winded way of saying yes, a lot of different strategies.
Thank you. Next question is from Teresa. So much of this comes back to brain inflammation, sensory symptoms, migraines, autonomic disorders. How can we get at the root problem of brain inflammation?
So brain inflammation, it's such a broad term. I think what I'm talking about is dysregulation and inflammation in the vessel wall of the body, and not inflammation in the brain tissue that we know of. We haven't in our studies found any evidence of that. And typically that shows up on MRI, which is why I'm looking for that in my MRI research study. And we haven't found, because when I think of brain inflammation as an MS doctor, I think of lesions, plaques, active immune invasion. And that's not what we're seeing in long COVID. And I think, I say this quite a bit, but I think long COVID is going to turn out to be a bunch of different things. So I don't think there is going to be one unifying diagnosis or thing, because all of the symptoms and the syndromes are similar, but everybody has like a slightly different long COVID case. And so they may have the GI involved and the brain involved, but they don't have the neuropathy or the this or the that, so it's similar pieces, but everybody has a different composition. So we'll see, but yeah.
Thank you. Next question is from Emily. What is the testing for vascular dysfunction?
So the vascular dysfunction is the best way to demonstrate it is to do an invasive CPET test, cardiopulmonary exercise test. That's what the research has been done on. They put a catheter down your neck to your heart. They make you exercise. They take your blood. And that is a way you can, and I think there's only one person in Connecticut that even does it, which is why I don't always recommend people get it, because if you have the classic post-exertional malaise, you meet the chronic fatigue criteria, you don't really need that test unless you're fighting really hard for disability, and disability can be very brutal and saying, oh, it's not real. You need like an actual objective, finding, then we'll push for it. I think one of the clinics was trying pyridostigmine, which was improving the test numbers on the test, on the CPET, but it wasn't actually improving people's symptoms, which is very interesting. And so, patients have tried that. I haven't heard or had good success with it. So not something I recommend, but that's the main test for it.
Thank you. Next question is from Michelle. It's a bit long, but we'll get through it. She asks, I was interested in hearing about mitochondrial response, neurological connections, and if you've heard anything about preload failure and systemic oxygen extraction. I just saw a study on autonomic function resulting in changes in arterial function.
Just talked about,
not allowing enough blood to ultimately get to periphery. Any thoughts on this?
Well, it's not the blood not getting to the periphery. It's not the oxygen is there. It's crossing across your lungs. It's in the blood. It's the tissue's ability to pull out the oxygen. And what we call it is like, it's like a very complicated net in the tissue, and the vessels, depending on exercise, will dilate or constrict depending on temperature, all these things. And it's that function that's not working well, and that's allowing this blood to pass by before your body can extract it, which makes sense, right? Why a lot of patients with the small fiber neuropathy or chronic fatigue have like cold extremities or really sweaty, or like there's a dysregulation in their skin, and there's a lot of autonomic symptoms with it.
Thank you. We have a question from Allison. Can small fiber neuropathy resolve over time, or is it permanent or progressive? What are some of the theories behind the cause this common long COVID, long vax symptom?
Yeah, I would love to know the answer to that. Because it's, again, not everybody's small fiber is identical either. So I have some patients, there's much more common causes of small fiber neuropathy. So one of them is autoimmune disease. So people with lupus or Sjogren's commonly will have a small fiber neuropathy. There's genetic causes, much less common. Then diabetes is a big cause of small fiber neuropathy. And so usually the people that don't get better have some other cause for small fiber neuropathy. So what you need to happen is the nerves, whatever is attacking the nerves, to stop attacking it. And then nerves take an extraordinary long amount of time to heal. So you need the trigger to go away, or the attack to go away, and then your nerves take months to heal on their own. And so it's just that picture of finding what is attacking your nerves. So, if IVIG has worked well in a lot of patients, in people who are a little more refractory, they likely have prediabetes or diabetes on top of it. I have one patient with MGUS on top of it, which is a blood disorder that can cause small fiber neuropathy. And I think a lot of cases get better because I've had so many patients come in with the typical small fiber neuropathy symptoms. And by the time they get into my clinic 6 to 9 months later, it's gone, it's resolved. So I think a lot of cases do get better, but some do need ongoing treatment. Yeah.
Thank you so much. Next question is from Fred. He asks, do you have an opinion about the opinions and claims of Dr. Peter McCullough, who has been in the news?
I don't have news or TV, so I don't know who he is, but I'll take a look.
It's good. It's
Yeah.
very, very good.
Yeah.
Me either, actually. So
only focus on so many things, right?
Okay, so next question. We have time for, I think, 2 or 3 more questions. For a question from Barbara. I am having SFN and dysautonomia since my vaccination. I feel like I'm improving, but I have COVID, but I have had COVID 2 times during that recovery, and it really worsened the symptoms long term. Do you think that it might also be an immunological aspect to it that is still going on, even with the vaccination 2 years ago? And how would I get my neurologist to understand that this might be the case?
I think that's a good question. So yes. So just like I was saying, autoimmune diseases flare with viruses and illness and any stimulation to the immune system. So, it does kind of sound like it. One of the things that I will do is send an auto antibody panel to the University of Washington in St. Louis. They have an excellent sensory neuropathy panel, and they test some antibodies that are linked with small fiber neuropathy. And so that having that positive test, which I've had in a number of post-COVID patients, can be another validating factor and another piece of the puzzle and provide an answer. And so I can provide that link. You can ask your neurologist if they'll order it. It would only, can't hurt the neurologist. So yeah.
Thank you. All right. There's a question. There's a lot of words I don't know how to pronounce, but here we go. Question from Michelle. What are your thoughts on stellate ganglion blocks and transcutaneous vagus nerve stimulation?
I think they're very interesting, and I really look forward to seeing the results of the studies on it. I've heard some really great things from the stellate ganglion block and the vagus nerve stimulation. It's one of those things. I haven't used either of them, but it's one of those things, risk versus benefit, right? So what are the downsides to vagus nerve stimulation? There's a list, and you can look out for those side effects, but is it going to harm you? Like taking some chemo type drug or whatever that's not proven, or doing some invasive I think not. So, I think those are things that I'd be interested in seeing the results from.
That's awesome. Just 2 more questions, both of them from Jeff. He asked, my cognitive issues are typically worse in the morning and improve somewhat later in the day. My sleep is affected as well. Are you seeing patients with similar findings?
Yeah, absolutely. Absolutely. So sleep, like I said before, sleep is really key. So, people are much more sensitive to sleep loss, deprivation, interruption. And so, the fact that your cognitive issues are worse in the morning does make me think, like, whatever you do, go to the sleep medicine doctor, get a sleep study, make sure to address whatever's going on in your sleep. And it's really, I don't want to say low hanging fruit, but it's something we can fix. It's something that can be treated and really improve quality of life and symptoms.
Thank you so much. And our final question, are you taking new patients?
Yes, but only in Connecticut, in person in Connecticut. Yeah, I know.
So it's great news for everyone in Connecticut.
Yeah, we have. I know there are other, I was trying to get AAN to post something about it, but I know there are other long COVID clinics out there too. So finding anyone who's familiar with COVID, and even some specialists, they've seen it so many times that now they're more open to it, right? It initially was like very closed, but it's really a proven entity now. So finding a good doctor is good. Yeah. Who's open.
Agreed. Dr. McAlpine, if you have any closing remarks before we wrap up.
No, I feel bad I wasn't able to answer all the questions, but send me the stuff and I'll put it up. I'll put up the answers.
Yeah. So everyone attending, if you want to reach out to me, either way, we're going to save the chat either way, so we'll figure it out. But if you also want to reach out to me with your question, you can do that too. We'll try to get those answered for sure. So thank you everyone for being here. This has been yet again another incredible event. I'm really, really, really glad to be a part of this. And it's great to see so many people attending event again and again and again. And today we had like over 200 people sign up and we had over 100 people here. So that's really incredible. It's such an engaged and amazing community. I mean, there's 79 questions, 80 questions in the Q&A and the chat's going off. So really just, it's an awesome group, and I'm grateful to be on this journey. We all are. So thank you so much to Denise and Pam for all your wonderful questions and for sharing your story. We're so glad to have you. And thank you, Dr. McAlpine, for your incredible, informative, thoughtful responses. It was a pleasure to have you. We hope to have you back in the future.
Yeah, and I hope to have more answers next time from the research and everything. Yeah. Yep.
Definitely. So yeah, that's all. Thank you all so much. Oh, wait, sorry, that's not all. One more, we have our next Kindred Cafe is going to be August 24th at 6 p.m. We're welcoming back Dr. Jim Jackson. So please, you can RSVP on the Kindred events page. We'll definitely be sending out emails. I think we sent one out earlier today, so check your inbox if you haven't seen that yet, and hope to see you there. Thank you.
Bye, everyone.